So I'll mute myself. Thanks, Sarah, and thanks everyone else for the interesting talk so far. So I'm going to talk about ketamine and the treatment of addiction. Just some disclosures before I start. Just move that. And I'm only going to talk about the psychological effects of ketamine today, not denying the neurobiology. And obviously, Jerry did an amazing job of covering it. And I hope perhaps we can get into a discussion in the breakout rooms of how some of these things relate to neurobiology. But I'm just talking about the use of ketamine in addiction treatment. And I guess this research has really had quite a different course to the depression work for a variety of reasons, I think. So I think there's very little research in this area for a starter, but perhaps getting funding for these studies has been even harder than in the work with depression, because people perceive this inherent risk of giving ketamine to addicts. And I understand this very well, as I've spent a good proportion of my career researching people who have ketamine problems and working with them. So I understand that can be damaging, but so I think also there's another a kind of a difference between the depression and addiction research, in that most researchers in this field, and there aren't very many of us to be fair, but have taken quite a different approach, historically intended to embed ketamine infusions in a psychological therapy context. And this approach seems to be gaining ground. I'm really excited to hear Jerry mention this and see Sam Wilkinson's talk about CBT tomorrow. So I think it's brilliant that more people are considering adjuvant psychological therapy, because to my mind, we're kind of missing a trick if we don't do this. I think perhaps why in addiction we've tended to embed ketamine within therapy may be to do with inherent risk, but also to do with the lineage of the research. So actually, ketamine research in addiction clinically has been going on longer than the depression research, thanks to this guy is Evgeny Krupitsky, who's a psychiatrist in Russia, and he was researching ketamine in the 80s and 90s in Russia and had to stop his program of research when the drug became Schedule 1 over there. But yeah, he's done an enormous amount of research looking at ketamine very much in the context of a psychological kind of transpersonal psychodynamic therapy. But Evgeny found some amazing results, actually. He gave high dose ketamine. So in this case, he gave 3 infusions of, it was between 2 and 3 milligrams per kilogram of intramuscular ketamine to a large number of inpatient alcoholics. So they were in treatment for alcohol use disorder. And what he found was these really remarkable reductions in relapse of about 40% at 12 months. So around only a quarter of the placebo group remained abstinent at 12 months, but actually 2/3 of the ketamine group, which is incredible. And he found similar findings in opioid addicts. So these studies weren't RCTs, but they're really important basis for the future work. And then after that, there was just a huge hiatus in research looking at ketamine and addiction. And I think as Jerry elegantly described, the emergence of the use of ketamine as an antidepressant really helped to kickstart this again and opened up a route to exploring these things in addiction. So there were some experimental lab studies. I did some way back looking at potential reductions in drinking following ketamine. And then Elias Dakwa at Columbia, who's really the other person who's done research in this area, began looking at cocaine, and he did some really interesting laboratory studies with cocaine users showing a reduction in desire for cocaine following ketamine. And then this is Elias's study, probably the first clinical study in, it was in cocaine use disorder. And he used the active placebo midazolam to compare to ketamine, which is a really good idea. And he, so they looked at cocaine use disorder. They were predominantly free-base cocaine users. There were slight differences between the groups in that in the midazolam group, there were more free-base cocaine users. But in this study, he gave, patients came to stay in the facility for 5 days. And on day 2, they had an infusion of ketamine or midazolam. And then this was embedded in mindfulness training. And then when they were discharged, they did mindfulness-based relapse prevention, which is a treatment used in addiction for 5 weeks. And you can see what I think is actually really remarkable about this is parts of retention. So in the ketamine group, there was only a quarter of patients dropped out. In the midazolam group, it was 60% of patients. But also these reductions in cocaine use over the treatment time after they've been discharged from the inpatient unit whilst engaging with the mindfulness-based relapse prevention. There was a reduction in cocaine use in the ketamine group compared to the midazolam. So that is really interesting. And Elias has also conducted a study in alcohol use disorder. So this is a pilot approach, giving a single infusion of ketamine after all patients have been given motivation enhancement therapy. So this is a kind of counseling approach that helps individuals resolve their ambivalence about engaging in treatment and stopping their drug use or alcohol use, and aims to evoke rapid and internally motivated change. So this was a brief succession approach delivered over 5 weeks. And then patients had a single infusion of ketamine or midazolam. And again, the retention here with ketamine was much greater. So in the ketamine group, there were no dropouts, but a quarter of the midazolam group dropped out. And this was just a note to myself, really, about the measure. So you can see here actually on the graph that in the ketamine group, there were much lower numbers of heavy drinking days compared to the midazolam group. And I think that's a really interesting, important effect. Now I was just looking, because the guidance on how to assess heavy drinking days from NIAAA is 4 drinks per day for men and 3 drinks for women. And we've just kind of accepted this in alcohol research, but I started to look, and I don't think there's any evidence that women or men are less likely to relapse after 3 drinks. So maybe proposing changing that. And actually there's some gender differences in this study that make that difficult, but I still think it's an important and really well conducted study with an active placebo. So in these series of studies, there's no investigation of ketamine alone in the treatment of addiction, but also it's quite difficult to tease apart what's the effect of the therapy interactively, because the therapy was given to everyone in Elias's study and only to one group in Evgeny's early work. So that's something we set out to do with our research. So this is also our research questions were, does ketamine reduce drinking and alcohol use disorder? And then we wanted to look to see if psychological therapy could enhance ketamine's treatment effects in addiction. So this was the design of our study. So we designed it, as I said, to assess the synergistic effect of ketamine with therapy. So we wanted to include a placebo, not just for the drug, but also for the therapy. So we called the study the CARE study, and this stands for ketamine in the reduction of alcoholic relapse, which also I think gave the study a little less off-putting feel to people talking about ketamine, because they had a sense of kind of care from the outset. This study, we were lucky to get funded by the Medical Research Council in the UK, and we included 96 patients with moderate to severe alcohol use disorder. And they were randomized to receive either 3 infusions of ketamine at 0.8 milligrams per kilogram, or 3 infusions of placebo. And then amongst those 2 groups, half of the ketamine group received our CARE therapy, which was a specially designed program, essentially based on mindfulness-based relapse prevention, but also including aspects about what we know about ketamine effects and to support people around the ketamine infusion. All people received alcohol education, and this was designed for the study, so we could include a placebo therapy, as I said. So it would control for time spent with a therapist, but with no active psychological component, because we know there can be non-specific effects of just spending time with an individual. So, and then similarly in the placebo group, half of those received the therapy and half of those received education. And this is an overview of the treatment. So patients were screened and they were fitted with an alcohol monitoring bracelet. So we used the SCRAM bracelet to measure alcohol through sweat, because about 1% of your alcohol is excreted. So they wore that for the duration of the treatment. And then, so upon randomization, so screening happened, people were required to be abstinent upon entry to the study. So if they needed to reduce down, they were given time to do so, or supported through a detox. On entry to the study, on their first session, they received an hour and a half of psychological therapy and then an infusion of ketamine, and they came back 24 hours later and received another session of psychological therapy. And they did this for 3 weeks. And on the 4th week, they had their final session, and all these sessions were an hour and a half. So they were learning psychological techniques with a relaxation or mindfulness exercise in the middle. And the relaxation we also did with the alcohol education group. So they had these 7 sessions in total of psychological therapy and 3 infusions. And then they came back at week 12, week 24, so 3 and 6 months for follow-up visits. So we had a lot of exclusion criteria. Some of those, which I just wanted to highlight, were taking antidepressants, because this meant quite a lot of people weren't eligible for the study, and I think is relevant to our findings. Current diagnosis of substance use disorder, and very poor liver function, which was quite limiting when working with alcoholics. Oh, and we excluded people with regular ketamine use, but if they'd occasionally used it up to 10 times in the past, that was permitted. So in terms of feasibility in our study, it would differ quite a lot from Elias Dakwar's work in that we had quite good retention. So actually only 1 person dropped out of each of the ketamine groups due to not being able to tolerate the drug. But for various other reasons, we ended up losing 7 people from the ketamine group. I mean, some of them were not being able to fit in with a quite intense treatment plan. We had change in eligibility when someone developed suicidal ideation, which was mild, but and then a few people were lost to follow up, so around 1 person in each group. So we had really good retention. But yeah, across the groups, it was broadly similar, but slightly higher loss from the ketamine group, so 7 and 5, and then 4 and 3. So obviously there's an intention to treat analysis. So that slightly impacts the outcomes. In terms of the patients we recruited, I won't spend too long on this because I'm conscious of the time, but overall, they were predominantly male, but quite a good gender split in their 40s. They had an average of 7 items endorsed, or 7 or 8 on the DSM-5, which meant they had severe alcohol use disorder and heavy alcohol users, but most were abstinent. And this is when they alcohol use at randomization. So some of them stopped drinking that day, but yeah, they'd managed to reduce down considerably. In terms of safety, this is a very small consideration of safety compared to Carla's amazing, huge studies, but we had a variety of AEs, but most of them were mild. The only severe one was suicidal ideation. The ones that you would expect, nausea and confusion, but no serious adverse events related to the drug. In terms of drinking outcomes, so our results panned out as we hypothesized. So the confidence intervals are wide, as you'd expect with a phase 2 study. But so if we take it from here, where this is the percentage of days abstinent, so on entry into the study, the majority of participants were abstinent, and then there's decreased to nearly 100% at the end of treatment. And then what we saw is a kind of divergence in effects here, where the placebo group drop off quite quickly. Their days abstinent reduces to 6 months to the lowest. So these are the placebo and education. The next lowest were the placebo and therapy, and then ketamine and education, and the ketamine and therapy did the best. And these differences are of significant in terms of the confidence intervals. So, and this is reflected in our some of our objective indices, which I don't have time to fully present, but we looked at liver function, and you can see here, so here higher scores are poorer liver function, and red are the placebo group. So they start out with poor liver function, which improves across the study. This is up to their end of treatment visit. And then the placebo group's liver function starts to worsen again as their drinking increases, but the ketamine group remain low. And just on some of our secondary outcomes, we have very low levels of depression in the study because we excluded people on antidepressants. And even though some people came off their antidepressants, and the reasons for that I can go into, which were more to do with the funder. But yeah, for that reason, we had low levels of depression, but we still saw a significant reduction in depression in our ketamine group compared to placebo at 3 months. This then tapered off by 6 months. And a similar kind of pattern with anhedonia, although it is slightly lower in the ketamine group to start with, but decreased over the course of the study, and then looks like it's starting to increase again, with a significant difference between the groups at 3 months. So a kind of interim summary, although I might just go slightly over time, I think, is that so ketamine on its own reduced alcohol use and severe alcohol use disorder, and this was maintained to 6 months, which is, I think, really impressive given we only gave 3 infusions embedded in psychological therapy. It suggested that this would enhance the treatment effects, so that our treatment effects on drinking were enhanced by embedding the ketamine within a psychological therapeutic context, and this was reflected in improvements of liver function. And we also saw reductions in depression and anhedonia at 3 months. These tapered off by 6 months. So I wanted to talk very briefly about some qualitative analyses we conducted. So I think these are really important when we're trying to understand the mechanism by which ketamine works. I'm actually talking to the patients involved, and they allow us to dive a bit deeper into how ketamine might work. And I don't have time to really do justice to this. These are the main themes that emerge from the qualitative analysis led by Marva, who's a PhD student, and Joe in our lab. And they were setting the contradictory nature of the ketamine experiences and transformative effects. I'll probably just go on to the contradictory experiences as we are quite short of time. But so a common theme that came out was contradictory nature of the acute experiences of ketamine, that there were things like a lot of fear, but also relaxation. And one of the contradictory experiences I identified was the sense of disembodiment. And these are some of the patient reports. The feeling of my body disappeared. It was like I was amoeba. As far as I was concerned, I was dead. It's like the universe was surrounding me and I was a tiny particle. But this kind of contrasts with a lot of the reports we also got from patients, that they felt this sense of connection during the infusion. We were all connected. There is the connection between all things to bring us out of the prison of addiction. And the sense of what was important was my relationship with the universe and the universe as a whole, the relationships with people, entities, nature, wildlife. So on the surface, this seems contradictory, but actually thinking about it, you could think this kind of disembodiment and disconnection would have as a natural consequence connection. So this disconnection from yourself means that inherently you connect with large areas of life that we're part of. So things like your relationships, nature, humanity. And this has been termed the small self in all research. And this sounded to us like quite an important therapeutic process. And it's something that Jerry mentioned briefly in his talk, that the literature around the relationship between dissociation and treatment outcomes has been quite equivocal. And actually, Miriam, who's a postdoc in our lab, did a systematic review looking at the links between dissociation and treatment outcome across all studies, and found in about 25% of studies, there seemed to be a link between scores on the CADS, which is the Clinician Administered Dissociative State Scale. But actually, that the majority overall, there didn't seem to be a net effect, which is quite interesting. We wonder whether maybe the CADS is not the best scale to assess this. And actually looking, this is a study from Elias, sorry, I haven't got the reference on there. I must have got chopped off. This is a follow-up study from Elias Duckworth's study in alcohol use, where they looked at the relationship between, this is the Hood Mysticism Scale. So it assesses mystical effects of drugs. And then they looked also at the CADS. And you can see there's a greater association here. So the scores on the Hood Mysticism Scale predicted heavy drinking days after the infusion. And the CAD score was only of marginal significance. I actually looked across our study, and we used the scale that I developed to assess acute ketamine effects quite a while ago in my PhD, I think. And it ranges from things like dizziness, nausea, impaired concentration, unsteadiness. And I aggregated the effects across the 3 infusions, and what we found was the most predictive, and it's quite strong, like a large effect size here, were out-of-body experiences, were the most predictive of the percentage of days abstinent at 6 months. So I thought that was really interesting. These are preliminary analyses, and I must caveat they weren't in our statistical analysis plan, so they're only exploratory. But I thought that was quite interesting. I don't know really, Sarah, would you like me to stop here so everyone can have a break? I could do about 5 more minutes, or what do you think?
Yeah, I would continue if it's okay.
Okay, cool. That's okay, that's great.
Sure.
I don't want everyone to miss out on their break. But yeah, so this I thought was quite interesting. This combined with what we'd heard from our patients in our qualitative analysis of these feelings of connection stemming from disconnection. And I started thinking about dissociation and disembodiment. So with out-of-body experiences, I think disembodiment might be a better term, or depersonalization, but that has some wider connotations. So we know that these kind of disembodied feelings or depersonalization occur in response to trauma. And this can be really damaging and really difficult when they occur unexpectedly and over prolonged periods of time. And we know they're a core feature in a number of psychopathologies. And I know we're going to hear about PTSD next, I think so. And we know, and understandably, that depersonalization has been viewed largely through a pathological lens. But it's still clear that nobody really has a handle on exactly why we dissociate when trauma happens. And one suggestion has been this is a kind of functional response of the brain to protect us from overwhelming anxiety. And so this might be able to enhance things like our chance of survival in a life-threatening situation by heightening our alertness and dampening down what could be very disorganizing levels of anxiety and stress. But actually, interestingly, another literature has found dissociative experiences occur in response to awe. So by awe, we mean the feeling of being diminished in the presence of something greater than the self. So this is normally inspired by things like nature and art or perceptual vastness. So this idea that dissociation and this kind of disembodied feelings happen in response to awe suggests that maybe the theory of the etiology of dissociative experiences in trauma might be incomplete. So what I wanted to tentatively suggest is that maybe these states are more than just an epiphenomenon of a protective process in the brain, but actually perhaps the psychological manifestation of a process of a way of encoding information in our brain that doesn't fit within our normal frames of reference. This also fits with the spike in plasticity in neurobiology, in the neurobiological studies that we see that happens following these events. So I think I'd be really interested to get into that in the breakout rooms later. So anyway, to kind of conclude, I've tried to draw this out. And so here I've kind of conceptualized awe and trauma, and awe by no means has to be a positive event, but sometimes is, as these kind of challenging experiences. And thanks to Irini, who's a researcher in our group, who's really helped with this. Yeah, so these are conceptualized as challenging experiences, and using disembodiment as a kind of broad term for disconnection between any of the normal thoughts, emotions, and bodily feelings. And so this can be seen as a kind of psychological manifestation of an adaptive brain state. So here I've called it an observer perspective, but this basically might mean that we're able to process and rapidly learn from extreme experiences. And maybe that's the function of these feelings and these psychological manifestations of these observer states. Obviously in all it's not in all contexts that this is a positive event. So with some of our ketamine infusions, we see growth, and this disembodiment is related to connection and integration, and that's probably very much the context around the event, because certainly in other circumstances, this may lead to things like alienation, fragmentation, and then getting kind of hooked back into a trauma loop, as it were. But yeah, I thought it's quite an interesting way of thinking about some of the effects of ketamine and how some of these processes of disembodiment and disconnection might relate to some of the treatment effects that we're seeing. So I'll skip over transformation, although it's obviously very important as part of the ketamine experience. This was the other main theme that came out of our qualitative analyses. But just to conclude then, so overall, there's an emerging body of evidence that ketamine improves outcomes in addiction. And it seems like it's better when embedded in therapeutic context, although our study is really the only one to have tested that so far. So related to what Jerry was saying, I would say that maybe the psychotomimetic and dissociative effects aren't in fact nuisance effects, that they're actually an important part of the therapeutic process. And they unlock psychological flexibility and enhance our motivation for change. And so I'd suggest that it would be important that we try and explore how best to harness these unique effects for therapeutic gain. So just wanted to say massive thanks to some of the key people involved in the study and Awaken Life Sciences who are taking it forward to phase 3. So yeah, I'll stop sharing now.